today. As you heard, we are today talking about mental disorder myth and the myths of mental disorders to kind of orient you to the topic. In the first part of this webinar, I will be talking about specific myths of mental disorders, of specific disorders that we have looked at in our research. And keep in mind that most of this research has been done with students, college-age students, though some go beyond that through social media. On the second half of the webinar, Dr. Curtis will be talking about the myth of abnormality versus non-abnormality. What's the line between the two? In a 2022 survey, we found that almost half of students believed that there was really no standards for differentiating between normal and abnormal. And so that kind of alludes to this larger myth that Dr. Curtis will be looking at in the second half of our webinar. All right, little technical difficulties here. There it is. So I'd like to start by asking you to consider myths that you've heard about mental illness. So just take a minute to do that. And I want you to think particularly about the character that these myths seem to have. Like, what character do the myths seem to have that you've heard about mental illness? I'm going to propose that there's a few, and that some of these at least, tend to blur the lines between normal and abnormal, or they make abnormal seem so far-fetched, so different that it really does an injustice to people who are suffering from mental disorders. So one particular kind of character of mental disorders that we've seen is that people with mental disorders are dangerous. And so we've seen this, it's really spanned several different disorders. Over half the students in a study of the myths of schizophrenia and bipolar disorder, in both of those, over half believed that individuals with schizophrenia or bipolar disorder were more likely to be a danger to others than they were to themselves. And so somehow this idea that people with these disorders are, typically they're more likely to go out and harm other people has seeped into kind of the belief system and the concepts related to these disorders. Depression wasn't quite so high, but it was still close to 40%, 38.7% of students that believed that people with MDD or depression are a danger to others. And so dangerousness it's interesting, right? So this is one area where there seems to be a clear difference between normal and abnormal. But it's also kind of the extreme end of mental health disorders, that there's this severe danger. It's almost like it's the last acceptable way to label something as abnormal is to see it as really extreme and pretty far out there, very, very different from the norm, and almost so different that I don't have to worry about that in my life. I don't have to worry about that in my experience. Something along those lines. So myths tend to take things to an extreme, and we've seen this in several studies as well. This is another character that we see of our myths, and we've seen this with regard to suicide, autism, and bipolar disorder in these various studies. Over 2/3 of people in a study about myths of suicide thought that most people who attempt suicide and fail, so they attempt and fail, will attempt again. 50% thought that they will actually succeed or complete suicide in the future. Interestingly, if you look at the data, within about 1 year, approximately 1 to 2% of people will attempt again in that year. So it's a relatively small amount that attempt right away. And oddly, about 80% roughly, people up to, I should say, as high as 80% of repeated attempts will complete within 1 year. But consider that's 80% of that 1 to 2%. So what does that tell us? Well, it tells us that really it's a relatively small amount of people who are repeating attempted suicide, and even smaller percentage than that that are completing it, although it's a large percentage within that small 1 to 2%. With regard to autism, 56% reported a belief that most people with autism have above average IQ. And the studies range, there's a pretty wide range there, but around 3 to 40%. And 56% also believe that people with autism have gifted levels of knowledge or talent. And NIH, the National Institute of Health, has said it's only about 10% of people with autism that are actually savants. So again, we see here this idea of, you have the disorder and you see the kind of the most extreme characteristics of the disorder as the disorder proper, rather than seeing it maybe as different than, but closer to the norm. Over half of the students in our myths of bipolar disorder believed that having bipolar disorder is the same as having no control over your emotions. And so, of course, that's really strong language. We did this on purpose to make it clearly a myth. But again, think of that. Over half of the people in this study thought that people with bipolar disorder had no control over their emotions. Even more extreme than that, 88% of students believed that several bipolar shifts happen in a really short period of time. And so, again, the idea here is, if we're going to see people shifting moods and call it disordered, it must be this rapidly shifting thing that go from one extreme to the other. And rather than, the truth, which is shifts for bipolar disorder can take months to go from a manic state to a depressed state and back and forth. And so that seems to be a misunderstanding that's kind of out there in the culture pretty strongly. Hopefully you're beginning to see the pattern here. It's something like, if we're going to call something disordered or abnormal, then it almost has to be really outside the box, really fantastical, really to an extreme. Otherwise, we almost don't feel comfortable referring to it or thinking of it as an abnormality. Now, interestingly, another characteristic we see that kind of is at the other extreme of thought is when myths confuse disorders with events of everyday life. We've seen this across several different studies, but we're going to focus here on this study, this more recent study on PTSD, because there were several different areas where we see that kind of confusion with of the disorder with everyday life. Is everything good? We had a little ding on our end, so I wanted to. Okay, good. All right, so with regard to PTSD, 64% of our participants believed that most people who experience a traumatic event will develop PTSD. So the idea of something that's more normative, a traumatic event, which the NIH says about half of US adults will experience a traumatic event in their lifetime. But again, the half that will experience that is much lower than the 6.8% of US adults that are diagnosed with PTSD. Now, there might be some room in there between, but still there's a large gap between 6.8% and 50%. Most people who have a traumatic event occur in their life do not develop PTSD. Another area that we see this kind of confusion between everyday life and disorders is the idea of being triggered. And so 62% of participants believed that being triggered is a normal experience that happens to everyone. And of course, what we can see happening here is a kind of equivocation with the word trigger, right? So on the one hand, we can use it kind of in like normal everyday life, where maybe I'm startled by something to mean, something along that line. But then on the flip side of that, with PTSD, it's a very different kind of triggering that's occurring. Interestingly, about 2/3 believed that trigger warnings help decrease anxiety, whereas we see from the literature that the opposite seems to be occurring with regard to trigger warnings. We've seen that it kind of undermines resilience and then increases anticipatory anxiety. So people anticipate the situation to be worse than it in fact is. 83% of people in this study believed that people can be traumatized by any event. So the idea is it's more about your interpretation of the event than it is the event itself, whereas the DSM criteria is very clear that it requires a person actually experience a serious threat to themselves or others. Some threat of death or serious bodily injury is kind of what we're looking at there. So now I want you to kind of consider the effect of this kind of myth, right? And because I think here we can see that this myth can be quite harmful, and minimize the suffering of people who actually have disorders, very much like the image you're seeing here, childhood trauma, make the best practical jokes. Well, I mean, when we think about that, there's a difference between someone dressing up in a costume and scaring you when you're a kid, and someone who has been severely harmed by someone when they're a child. And so to blur those lines really does an injustice to people who are struggling with PTSD and have had really serious traumatic events. Overall, the result I would submit is something like that we lose this sense of the difference between normal and abnormal human experience. And in order to call it abnormal, as we saw previously, we just take it to the extreme. And that's where we will feel comfortable calling something abnormal. Otherwise, we kind of get rid of the language of abnormal and we try to see things as normative. With that, I'm going to hand it off to Dr. Curtis.
Well, hello. So it's a pleasure to be here. And my plans today really are to unpack more specifically this pendulum between floating back and forth that Dr. Leslie Kelley talked about, normal and abnormal, and really seeing kind of where we've come from, where we are, and then some of the potential struggles of doing that, and really making a case for saving abnormal. And I want to unpack that a little bit. I'm going to start off with introducing you to this moth. In 2013, this newly identified moth species, the Spilocema wildi, was found and named by a family that discovered it in Papua New Guinea, Mike Wild and his family. And so I want you to think about how many of you are just disgusted by the fact that naming moths has gotten out of control. I mean, how many of you believe that naming moths has spun out of control? We need to stop this practice of naming and identifying new species. How many of you think want to come up with new names? Is this a pathologizing moths? Is it a pathological characterization of species? So when we think about in terms of that, one of the things that I've found very fascinating in the years of teaching abnormal psychology and presentations and research on this topic is that this is the one profession, specifically clinical counseling, school psychology, the applied practice of psychology, where the public has a real concern with labels, right? And so this idea, this controversy of too many labels, controversy of diagnostic inflation, name calling, being out of control, this is something that's creeped up and become pretty prevalent in clinical counseling, school psychology. And it's fascinating to me that we don't see it the same way as we see it in the practice of auto mechanics. We don't see it the same way as we see in the practice of medicine. We don't see it the same way as we see in the practice of biology and taxonomy, specifically with identifying new species. We don't have a problem with identification of new diseases, new species, but there does seem to be this problem with generating more psychological diagnoses, too many labels, and the controversy there. And so one of the controversies are practitioners haphazardly cranking out this disorder mill where we're just pathologizing normal. Is big pharma seeking to get more money from pathologizing normal behaviors? And so this controversy is really specific to our field. And I want to introduce you to a little bit of history from the DCM as we think in contrast to medicine. We talked about with the ICD that has over 17,000 diagnostic categories, over 100,000 medical diagnostic index terms. We don't seem to have the same passion about more medical diagnoses as we do within the field, specifically with this text, the DSM-5 TR. And so when we look at the history of this, the DSM-1, 1952, had 128 diagnoses, and I'm going to show you through the progression over the years with the updated DSM and where that lands. And so you think of the DSM-5, that previous slide, where has this gotten out of control? If you look at the difference from the DSM-4 TR that had 297 diagnoses within the text, 13 years later in the DSM-5, this controversy only included one more diagnostic category. And if you look historically since the 50s, it hasn't been a significant increase. You see from DSM-2 to DSM-3, there's some increase, but relatively stable throughout the years. That it's not this image or this myth that practitioners, licensed psychologists are cranking out and pathologizing every normative behavior that we can. In fact, arguably, it's really the opposite. The evidence isn't showing that that's what's happening. Now, you would notice that there is an increase in the size of text, and if you've ever owned a DSM, you know it has gotten bigger and bigger. A lot of that, I won't spend too much time here, but a lot of that is for specificity, specifically with the context of identifying research markers and to help clinicians be more specific in the tools. So this controversy has even been published by one of the chairs of the DSM-4 task force, Dr. Alan Francis, published this book, Saving Normal, and really discusses these out-of-control psychiatric diagnoses, the DSM-5 and the controversy moving to DSM-5 with these out-of-control diagnoses. And Alan Francis makes the case we need to save normal because essentially if you haven't read this book, I would encourage you to do so, that the arguments are practitioners, we've gotten out of control, we've created too many diagnoses, and it's this tool that's a bad tool. So rather than saving normal, what Dr. Leslie Kelley was talking about, this pendulum to where we might confuse psychopathology with normal events, we make the case that what needs saving isn't normal, rather what needs saving is abnormal. So people who are truly suffering from psychopathology that show up to the office, that show up to the clinic and say, please help. And if we say everything is normal, and we confuse that, and we really have a flippant attitude and a dismissive attitude towards people who are truly struggling. So we make the case that normal doesn't need to be saved. We need to save people who are suffering, abnormal behaviors, people who are struggling. Okay, and in doing so, I get that there's some resistance to this. And one of the things that tends to pop up as we think about saving normal, or even in the discussions, teaching abnormal psychology, within the title, abnormal psychology, there's this prompt to define what is normal, what is abnormal in this definition. And many people have evaded the definition altogether. And I've been trying to understand this, and it made sense basically through two perspectives. One of the challenges, I think, why in psychology and the history of humanity have we struggled with defining normality is, I think I'm going to be charitable here. I think it's two reasons. One is a confrontation with yourself. So if we were to advance a definition of normal, then you might confront yourself and say, do I fit that definition? Do I fit in that box? And there might be this fear of, am I normal? But even the question of am I normal is a developmental process that we all face psychologically, typically in adolescence. Eric Erickson, as we go through identity versus role confusion, this is a normative process to ask, am I normal? And are the things I'm thinking, doing, feeling, do other people have those thoughts? Am I human like other people? Where do I fit? Where do I belong, etc.? And so this pops up, as well as sometimes this notion here, that the saying on this t-shirt, that normal is just a setting on a dryer. And this is really advancing a kind of relativistic notion that there is no such thing as normal. It's normal is only a setting on a dryer. So when asked to define normal and define abnormality, people might be evasive. People might say, well, it doesn't actually exist. It's just a setting on a dryer. What this does is evades the definition altogether. And what I think it really does at the cost of people who are truly suffering, who say, look, what I'm experiencing is not normal. I used to live life fully, and now I'm struggling with suicidal thoughts, struggling with getting out of bed, and I really need some help. So it can be a flippant dismissal of people who are suffering. And so I think, to be charitable, I think the reason people might take this approach is because of fear of judging others, right? We're concerned if we set some definitions and parameters for normality and abnormality, we're scared that we might then look at others and start categorizing them as such. Now, categorization, I'm going to get to here shortly, isn't necessarily the problem. Now, if you're categorizing people and being ill-mannered and malicious in doing so, that certainly is problematic. So I think the fear of setting these boundaries really are fears of judging. And so one of the things that Dr. Leslie Kelley and myself have done is we've set forth a definition of normal and set criteria within our textbook for abnormal. So in abnormality, the criteria, one of the things, the controversies here with normality, it's even popped up in APA recently within Task Force Division 2. Should we remove abnormal psychology? Should we change the name of that course? And so I think I would make a strong case that we shouldn't, that we need to save abnormal, because what we're talking about isn't abnormal people. We're not talking about normal people. We're talking about specific behaviors, right? So our criteria definition here of normal and abnormal is looking at 4 F's. So looking at the frequency of the behavior, the function, if it's leading to the individual feeling pain and putting them at a risk of fatality or fatal. So very important to delineate and separate this and label this so that we can truly categorize people who are suffering, people who say, look, I have been fine until the last year of my life. Now I'm struggling in school, hard for me to get out of bed, don't want to eat much, anything that looks like major depressive disorder. If we say, well, that's normal, then we quickly dismiss their suffering. And then we, in a way, would say, well, we're not willing to help you because what you're experiencing is normal. And I think most practitioners would have a hard time with that. And I think most people would have a hard time with that as well. And so as we evaluate this idea of the DSM and as being a faulty tool, one of the things that the case that Dr. Alan Francis and others might make is the DSM is a faulty tool. It's a broken tool. And so we need to reduce it because it's gotten out of control. I would make the case that the tool is not necessarily the problem, but it could be the problem of user error. So we need actually better tools, and we need more specificity in the DSM, which is where the DSM has gone. The DSM being more specific and essentially adding to the tool belt of most practitioners are further going to advance and identify people who are suffering. I won't take us off the track too far, but some of the recent work I've been doing with pathological lying find that to be the case, that many people are reaching out to me saying, look, I need some help. And if we can't recognize this as a psychological disorder, these people will continue to suffer in silence. And so I would make the case it's not the problem of the tool being broken, but it's the problem of user error. So I do agree that clinicians need to be using these tools properly and not misusing them. And if we do that, we can ultimately help people better. And so I want to draw your attention to this quote from Blashfield and Burgess. I think this is probably paramount to helping us understand the history of classifications, why we even have the DSM, the early history of Philippe Pinel, Carl Jaspers, early individuals who developed nosologies. And it's just as water is basic to human existence, classification is fundamental to human cognition. This is what we do as humans. A fundamental operation is categorization, is classification. And it helps our nomenclature, helps us understand, helps us deepen concept formation, and really ultimately helping to intervene and help others. So to demonstrate this, I want you to think of a dog. So take a moment and in your mind's eye, think of a dog. Think of what comes to mind. Is it this? How about this? Maybe this one? These? Or this? So as we think about dogs, are there too many names for dog breeds? Do we have a problem with all these different names of dog breeds? We kind of think that this is ridiculous. There's a utility of thinking of having a label for Dalmatian. Dalmatian brings up a certain image. And if we move from Dalmatian to Pit Bull, we have another image. And if we move from that to Shih Tzu, we have another image. If we move that to Doberman Pinscher, we would have another image. And so all these specific names bring up deeper conceptualization for our cognition, right? So the argument isn't there are too many labels. It's helping individuals use these labels correctly. And so with that, diagnosis is not stigma. Diagnosis is not a monster. This classification, why individuals ever developed got into the field of clinical counseling psychology was not to go to local stores and stigmatize people, name calling. It's not to get back at people who bullied you in high school. But the reason we do what we do is to help people. And to better help people, we need better classification and better understanding of what's going on. And if we can recognize that, there's so many more pragmatic applications. Insurance will pay for individuals. We can look for empirically supported treatments. In some, we can ultimately help people better who might be suffering in silence. So with that, we'd like to say thank you.
That was outstanding. Thank you so much. I do have a couple questions from the field. And if you have more, please send them my way. First one, will the slides be available after the presentation? I know we're doing a video recording, but would you be willing to send PDFs of your slides?
Yes, absolutely.
Great, great. Have you gotten any pushback on your definition of normal?
We have not yet, and I would encourage people to push back, to refine it, to make it better. That the process of science is a refinement of ideas and knowledge, and I think you have to start somewhere. And so I would encourage everyone who's attended today to give pushback, to make it better, to help advance the definition in a way where we might be missing things. So I would applaud and encourage anyone to do so, and would welcome to hear feedback on that.
We have had people ask questions after presenting about, normal versus abnormal. But they're kind of along the lines of Alan Francis, where they have maybe some concern, but it's somewhat vague in terms of, are we labeling too many things as disordered? And so they're trying to make sense kind of where is that line between normal and abnormal? And that's basically what we're trying to do. And we're trying to do it in a systematic way so that we can kind of move the discussion forward. So again, I would reiterate what Dr. Curtis said. Any pushback we can get, or comments, or help in our work, then please do reach out to us.
Super helpful, super helpful. There was a question in the chat about some new diagnoses or disorders being in DSM-5 TR. Were any removed? from the previous versions that you're aware of?
Yeah. So yes, some have been kind of faded out and some have come in, and there's some that, are kind of edgy and people have a little bit of difficulty with them. And so, there is change, and what we're not saying, and speaking for myself, I think I speak for you too, that there's no error in the DSM, or that we're not going to refine it and make it better. Hopefully we do refine it and make it better, and keep taking things out that don't quite make sense, or that maybe we see that there's different relationships. So this happened really from 4 to 5, DSM 4 TR to 5, that where we had a broad category of mood disorder that include both bipolar and depression. They kind of more work had been done on bipolar disorder and saw it kind of closer in relation to schizophrenia. So then they changed up the way that things were categorized, and you see that you had schizophrenia, and then a category 4 bipolar disorder proper, and then you have just depressive disorders. And so we expect that there will continue to be these kind of shifts in our language. What the bigger picture is, we need the language, and we need to keep clarifying it. You had mentioned that it helps us to understand better, and I was thinking when you said that, like, it also helps us to have empathy, right? Because when we understand what someone else is going through, then it kind of tugs at our heartstrings, and we want to help them more. So I don't necessarily see
it helps patients also understand
absolutely
better, rather than the catch-all label of crazy that is dehumanizing. It helps them lean into it much more.
Yeah, and so I don't necessarily see a kind of conflict between the empathy and the labels. The labels help us to understand better, which then can help us have more empathy. That is, of course, unless we're like trying to eat some soup with a fork, is like when we're using the labels poorly, then there may be stigma and harm attached. But that, I don't think, is what most clinicians are trying to do. They're trying to use the labels to help people understand their lives, and to help them, with improve their treatment. And that includes deep empathy, usually, that clinicians have for their patients.
That's right. And one last thing there, if we make the case in our textbook, if you can move away from catch-all phrases like crazy, nuts, lunatic, and help people understand the symptoms of what's going on, then you can really help restore humanity to individuals. And so people can leave with a better sense, and for students would be better educated about what's going on with people, that it's not abnormal people, but there's abnormal behaviors that look very specific, and that deeper education understanding is a socio-political responsibility we take very serious, and it is a way to educate individuals, remove stigma, and ultimately restore humanity.
Yeah, that reminds me of a particular patient that I worked with, where she had been struggling for years with mental health issues, and had received several different labels. And finally, we did some testing, and we kind of landed on borderline personality disorder. And that's, generally a pretty severe disorder that does have, some kind of cultural baggage attached to it. But her experience of receiving that diagnosis was just one of almost deep appreciation, right? Like, finally, I really understand what is going on with me after all these years of struggling and all these different labels. And it helped her understand her struggles in a way that she could then start to be more mindful about how to treat them, and how we could treat them together in our work together.
Drew, thanks so much for mentioning the book. I should have talked about that. These two are the authors of Abnormal Psychology, Myths of Crazy. And we'd love to get a copy sent to you if you consider it for course adoption. If you are interested, please reply in the chat, and we'll get a copy sent to you. Do you have time for a couple more questions here?
I think we have a little bit of time. Yes.
Let's see. Can you delineate between abnormal and clinical? And if so, how do you see the relationship between these two terms?
delineating between clinical and abnormal. So for us, abnormal behavior is essentially the criteria we use is the 4 F's, which is in the textbook. We have some publications on this as well. And it's not necessarily specifically novel. It's an adaptation of the late Susan Nolan Hoeksema's criteria, the D's. For us, the F's, we made a little more specificity of the F's with frequency. Frequency is an amount of time. It's an increase or decrease of a specific behavior and frequency within the population. And so the abnormal definition, the abnormal criteria really, to our estimation, better maps onto the DSM-5. So you have this broad definition of how to understand abnormal behavior. You see it map onto the psychological disorders, which you could say would be the clinical aspect or the clinical psychopathology.
Yeah, some of my work is on synonyms in psychology and how we kind of confuse ourselves sometimes by having these overlapping terms that are somewhat similar but not completely similar. So I think that's a good example of it, where we sometimes use the word clinical just to mean a practice or something else, and then other times we use it to mean abnormal. So there are times when clinical is used in a way that is synonymous with abnormal, but it's not consistently, which is one of my pet peeves. So I won't get into that research, but I definitely like when we can use our language in consistent ways that help bring about clarity rather than more confusion.
What are your thoughts on the rise of victim culture? Is that tied to your idea of perceived threats versus physical harm?
The rise of victim culture, and what was the second part of that?
Is that tied to your idea of perceived threats versus physical harm?
Is it tied to perceived threats versus physical harm?
I mean, broadly, my response, I'm thinking about this is some of that pendulum we're talking about. If not to assume individuals haven't been victims, not to assume that individuals haven't experienced suffering or haven't had the world happen to them or haven't had any internalized thoughts that have caused them problems. But you can move that, and people, I think, do move that pendulum the other way, where they might say something like people aren't, everyone's suffering, or everyone has major depressive disorder, everyone has autism. And I think when you move it that way, where you kind of make the generalization that we're all victims and we all experience psychopathology, then you truly do, I think, dismiss individuals who are suffering, people that are going to clinicians and truly saying, please help me. So I think it's a delicate balance. I think it's individuals go on both sides of the pendulum in extreme. Not sure if that addressed the specific question.
My mind, and forgive me if this doesn't address the question directly, but my mind goes to some of the trauma myths that I discussed briefly. It kind of, with that word trauma, of course, we see it used culturally and broadly, and then we see it used in more refined, psychological settings. And so then, what happens when we have, a cultural kind of use of the word trauma, and it kind of, anything can be a trauma. That's not to dismiss people's own interpretation of events, which can then be overwhelming to them and may even mean that they need to seek out psychological help. Absolutely, our own interpretations of events, both of us kind of hail, at least to some degree, from a cognitive perspective, and so we believe that those interpretations can, in fact, need some help from a clinician. That, on the other hand, I think we also want to be careful about keeping the use as we see it in the DSM in terms of the diagnosis of PTSD and the kind of popularized use separate, because there we can, I think, blur the lines between someone who had, maybe it was overwhelming experience, but it wasn't traumatic proper, and then versus someone who had a life-threatening, serious potential risk to bodily harm to themselves, and then does develop a traumatic stress disorder. And so there's ongoing discussion, I think, about these things, but we do want to keep some of that kind of popular usage, I would suggest, separate from the clinical usage. I think it's more helpful to have at least some way of delineating between those two.
And one last thing there, I think if you're sensitive to, you talked about victim culture, victim mindset. I mean, sensitive to people's pain and suffering. I think that's what draws people in. As teaching abnormal psychology, helping people understand that these disorders, it's not otherworldly. What we're looking at here are experiences of human, and humans have suffering. But if you look at the criteria imposed on that, then you can help people size up the difference between suffering that is normative and suffering that is pathological, that's really causing problems in your living, your functioning, great amounts of distress, and posing some risk of danger to self. And if you do that, I think it further helps people understand their own suffering, where they are, and in relation to others who experience psychopathology.
And one final question here. This instructor has stopped covering the sexual disorders chapter due to unease covering gender dysphoria. What are your thoughts on this disorder, and do you think it will be removed from the DSM in the future?
I think that's a good question, worth consideration of how do you manage that in teaching abnormal psychology or a variety of psychology classes. I think the other question is probably lengthier than we have time for. The controversy, we saw this from the DSM-4 TR to the DSM-5, even the DSM-5, the DSM-5 TR, the ongoing discussion about gender identity disorder, gender dysphoric disorder, and there's reasons why it's largely been retained. I'm happy to discuss that. I think it's a great opportunity to engage students. So when I teach it in abnormal psychology classes, I discuss it at length and really try to get students to engage. I find that students are probably maybe equally or more uncomfortable, as you're mentioning, in discussing some of these topics. Some students might shy away from that. And so I think what better place than to have these discussions than the academy. And so I encourage the discussion, the different viewpoints, where it makes sense to retain it, why it's been retained, the controversies. Now, I certainly know maybe I'm alone on that. I think for good reason. Maybe there's reasons to not want to teach that. But if it's a concern of taking a stance or another, I think one pedagogical approach is putting out the information, talking about both sides. The late Scott Lilienfeld, authored a book years ago, Taking Both Sides, and really puts the question, puts the controversy, and then arguments for and against. And I think if you can do this within a classroom, I think it'd be really productive if you kind of moderate that discussion as well, help individuals rather than just potentially be harmful, if that's the concern, to turn that into good dialogue.
Yeah, and I think it's possible to have respectful discussion, even though I totally can feel the pain there. It's difficult to kind of go in that direction, and it may be difficult to have these more sensitive kind of conversations and discussions in a classroom. We do have a chapter in the book, so please check that out, and you can see kind of how we handle the content in the book. Most of it is just kind of a clear explanation of the research and the position as it is in the current DSM-5 TR. So, and it just kind of lays out the material there, and then it would be really a great jumping off point to have deeper discussions around that topic.
I love that approach. Great suggestion. Thank you, Dr. Curtis and Dr. Kelley. Thank you so much. And thank you to everyone for participating in today's discussion. Our sales representative, Beth Slotz, will be in touch with you in the coming days. She'll be sending you a recording. Also, if you're interested in a copy of their book, Abnormal Psychology, Myths of Crazy, please respond in the chat or reply to that email, and Beth will get you access to that. Once again, thanks so much for joining us today. Any final words, Drew, Leslie?
It's been a great pleasure. Thank you all for attending, and feel free to reach out with questions, push back on definitions, help out in any way. We hope we can provide you with resources that are useful for you if you're an educator, practitioner, both. So thank you for your time.
Yes, and I would add we love discussion and hard questions. So please do feel free to reach out to us, and we're glad to continue the discussion offline, so to speak.
Thanks so much. Have a great day.